let's do our next obstructive pulmonary case, and that is cystic fibrosis. Cystic fibrosis is another one of these lung pathologies that we didn't cover in pathophys because I kind of save it for here when we're talking about all of this secretion management. So while some of you are likely familiar with this disease, this is the first time that I'm presenting it to you as I left it out of pathophys. So our case is a 35-year-old female named Julia. She was hospitalized with an acute exacerbation of cystic fibrosis. She had been diagnosed by a sweat test at 2 years of age when she failed to gain weight, even though she was eating a diet more than adequate for her growth. So this situation where someone is not gaining weight is called failure to thrive. And it's a clinical symptom of the GI tract that would lead to further testing when a baby is born. So newborn screens do differ state by state, but almost all they screen for cystic fibrosis. How they do it can be different. In some cases, they do a blood test only, and some states do a blood test with a DNA test. So the blood test is looking for increases in a chemical made by the pancreas that can be suggestive of cystic fibrosis. And the DNA test is looking for mutations in the CFTR genes. So depending on which state you are, which test you get, most cases of cystic fibrosis, more than 90% of cases, are identified by newborn screenings. The 10% that are not diagnosed early on typically don't get diagnosed until adolescence or early adulthood. Cystic fibrosis is an inherited autosomal recessive disorder that's present in about 1 of 2,500 births. Because it's autosomal recessive, you must harbor mutations in both genes. And the genes that are associated with cystic fibrosis, there is a wide range of mutations of this SF-associated gene. So because of that, a patient that has a diagnosis of cystic fibrosis has a really wide variety of clinical phenotypes. So you can't assume that kind of all the things that could happen are there. It really depends on the type of mutation they have. Primarily, this mutations of the CF gene result in an epithelial ion transport dysfunction. So this mutation alters, as you can see on the slide here, the CFTR, the cystic fibrosis transmembrane conductance regulator. And these mutations either cause reduced production of CFTR or abnormal function of CFTR. Either there's not enough of it or it's not doing its job well enough. But in effect, you make the membranes impermeable to chloride. So it's impossible for chloride to cross these epithelial cells when CFTR is either absent or not functional. So you can see up on top here in the healthy individual that this is a chloride channel that allows chloride to move across the epithelial cells. The result of this is that you increase sodium reabsorption, that these epithelial cells take up sodium. So this occurs in epithelial cells in the respiratory tract as well as in the intestinal tract. Now, if you remember, water always follows sodium. So when these epithelial cells take up the sodium, the water follows, and you get this water moving into the cell. We increase the passive water reabsorption, so you effectively dehydrate the surface fluid layer. So if you look at the healthy individual, you can see that the area that's right by the cilia of these epithelial cells is kind of cartooned as a blue layer of very hydrated mucus that would easily move along these epithelial cells. When all of the water moves into the epithelial cells following all that sodium reabsorption, the mucus and the secretions of the airways become extremely dehydrated, and this increases the viscosity of the secretions. the secretions become very thick. Because of this, these thick secretions aren't easy to clear and they end up blocking airways. Kind of similar to the story with bronchiectasis, if you have blocked airways with secretions that can't get out, this is a breeding ground for recurrent chronic airway infections. In fact, cystic fibrosis is one of the causes of bronchiectasis for this exact reason. These high viscosity mucuses can also block the pancreatic ducts, and this can result in pancreatic insufficiencies. So our pancreatic enzymes are really important to help with food digestion. Patients who have cystic fibrosis and have pancreatic involvement suffer from malabsorption. They don't gain weight well. They can end up with abdominal distension. Large, foul-smelling stools are common because of the decreased ability to digest their food. Now, from the medical side, we can treat patients with pancreatic enzyme replacement, so we can have ways of helping patients deal with decreases in pancreatic function. The other thing that should probably be on this list, we talk about it in just a minute in the flow chart, is liver effects. And what's interesting in kind of the progression of a disease is that our ability to medically treat cystic fibrosis has increased just exponentially in the last several decades. And so patients were dying at a much younger age of cystic fibrosis just 40 or 50 years ago. Now that we've gotten these better treatments, patients are living long enough that they're actually developing liver disease as a result of the mutation of these epithelial cells, and we will talk about that. I want to show you this brief video because I think they do a really nice job just illustrating the pathophys of the lack of this transport. So I'm going to let the video run and then we'll pick back up with the effects of cystic fibrosis on the bottom of your note page.
A patient with cystic fibrosis is susceptible to infections of the lungs. This is due to a mutation that affects a protein on the surface of lung cells. Many different mutations can cause cystic fibrosis, but all of them involve a transmembrane protein called CFTR that functions as a channel for chloride to move in and out of cells. In this case, CFTR is less able to transfer chloride ions out of the cell compared to the functioning protein in people without cystic fibrosis. The channel is, in effect, locked shut. This inability to transfer chloride ions has an effect on the outside of the cell. In people without cystic fibrosis, there is a balance of chloride ions inside and outside lung cells, which maintains the right amount of water and salt ions in the mucus lining the airways. Cilia normally sweep the watery mucus from the lung lining, keeping the surface clean. In patients with cystic fibrosis, chloride ions concentrate inside cells and draw in water by osmosis. With less water, the mucus becomes thicker and cilia can't move. Flow is reduced, providing an environment for bacterial infection.
So let's look at the effects of changes in this one small channel and how it has these broad effects through multiple systems. We often think the most about the lung effects with cystic fibrosis because, as you could see from that video, as the secretions become thick and the cilia become ineffective, it obstructs the airway with mucus. This secretion accumulation leads to chronic cough. You get hyperplasia and hypertrophy of the mucus secreting cells. The body tries to handle the negative effects of this accumulation the only way it knows how, and that's by making more mucus, which just makes the problem worse. It ultimately causes distended bronchioles, and then warm, wet environments love to grow bacteria, and they end up with recurrent chronic infections in the lung. They also have a lot of GI effects because of the epithelial cells of the GI system that also are affected by this gene mutation. So with the pancreatic ducts getting clogged, they can end up in pancreatic insufficiency. And because they can't effectively release digestive enzymes, they have decreased protein absorption, decreased fat absorption, and some vitamin deficiencies. As I mentioned, the treatment with pancreatic enzyme replacement can really help with a lot of the problems related to the pancreas. But the liver can also get plugged from the thickened secretions and fluids that should be normally moving through the liver, and can ultimately lead to fatty liver disease. The reproductive system can also be affected. In men, there is either an absent or obstructed vas deferens, so many of the male patients with cystic fibrosis are infertile because of this reason. So, in your initial introduction to this case, it mentioned that Julie was diagnosed with a sweat test. On the top of the next page of your notes, it just talks about the diagnosis, which I kind of already hit on in the intro, that most of these cases are caught in the newborn screen, but then a sweat test is used to confirm the CF diagnosis. Basically, a patient who has cystic fibrosis ends up having about 2 to 5 times the amount of NaCl in their sweat than a normal person would. And this quote is so interesting that in ancient European folklore, there was a known saying that if an infant tastes of salt, they will surely die. So this was recognized very early on that this high level of NaCl was associated with this very young death in babies, even though at that time they had no idea why. So this chart is looking at just how far we've come in terms of treatment, and you don't need to know this necessarily, but it's important to kind of note the timeline. So it was just in the mid 1940s, 50s that we started being able to treat patients with pancreatic enzymes. And then it was between 1950 and 1960 that airway clearance really started to become an effective tool to manually drain these secretions out. As antibiotics got better, so did how long these individuals were living with cystic fibrosis. Once we had an effective lung transplant, we see a big spike in how long patients are living. We're adding on additional treatments, and then this is all the kind of what could come next. How far could we go to help these patients live their full life as best as possible? So this is a relatively new disease to be living a longer life with. So we're learning a lot about what happens later on in life. That's why these liver complications are becoming a larger aspect of this patient story, because they're living long enough to have their livers affected. So I just wanted to give you this patient's past medical history because I think it's helpful to see how far she's come with this disease. So she was treated in an outpatient pediatric clinic until she was 18, and then she gets transitioned to an adult clinic. By age 24, she had repeat lung infections that no longer responded to oral antibiotics. When antibiotics are delivered via IV, you can do a much more potent antibiotic than oral. So many patients with cystic fibrosis will get an indwelling catheter that will make it much easier to administer their multiple courses of IV antibiotics. Some patients have difficulty maintaining the patency of a peripheral IV, so they may get a peripherally inserted central catheter for that exact reason. So by age 24, she is averaging around 7 hospital admissions per year. By age 26 is when she got her indwelling venous catheter in her right anterior chest. At age 30, she got a G-tube, that's a gastric tube, that was allowing her to help maintain her weight. So she was doing nighttime feedings to supplement her oral eating in order to gain appropriate amounts of weight. By age 34, she was placed on a lung transplant list. Her past medical history includes sinusitis. She's very prone to sinus infections. Otitis media is inflammation of the middle ear. She has reduced bone mineral density because of the frequent use of steroids. She gets bronchospasm, pancreatic insufficiency, and hemoptysis. So So this is what she has been doing currently to manage her diagnosis. She does airway clearance 3 times per day, and she does an exercise bicycle at home 3 times a week. She does a nebulized long-acting beta agonist, that's this guy here, 2 times a day. She has a metered dose inhaler for a short-acting anticholinergic and a corticosteroid. She is on a DNase, which is kind of a cool drug. It actively digests DNA in the sputum, and it ultimately reduces the viscosity of the secretions. She gets pancreatic enzymes with food, and she does antibiotics by mouth and via her indwelling catheter for the harbored infections that live in her mucus. So for the present illness, she was admitted because she had increased weight loss and decreased exercise tolerance. She's 110 pounds and 5'6" with a BMI of 17.8, which is very consistent with CFers that it's hard to maintain weight. She had been using 2 liters of oxygen continuously and a non-invasive intermittent positive pressure ventilation at night. That's this guy's non-invasive positive pressure ventilation. She required 4 liters to maintain oxygen saturation at 92%. She reports increased sputum production. She has pain with coughing secondary to GI and musculoskeletal symptoms. So she has orders for PT to evaluate and treat. On admission, her ABGs show her oxygen levels at 55 millimeters of mercury, satting at 86. So she needs more oxygen. We need to get these numbers up. Her chest x-ray shows hyperinflation with a flattened diaphragm and a kyphotic spine. She has increased interstitial markings in a cystic bronchiectatic pattern. So you can have a lot of distended airways visible on the chest x-ray. And then it lists the antibiotics that she is on at admission. These are her pulmonary function tests that were taken every 3 years. And the data from this patient is now getting a little old. So this 2017 would be a recent, that's when this data was recorded on this patient. But you can see that her FVC has just been progressively declining every 3 years, as well as her FEV1 is just going down. Each time they've done these tests, there has been a progression of her disease here. In cystic fibrosis patients, they really put a lot of emphasis on the FEV1 because FEV1 correlates very closely with survival. So you do your systems review. She's alert and oriented ×4, and she has no difficulty communicating with the healthcare team. And this is just a time, if this hasn't already crossed your radar, that it's really important to respect those individuals who have a lifetime history with a disease, because they're typically very well versed in their disease. And it's a very different thing to walk into the room of somebody who is, like our last case, this woman was just given her diagnosis of bronchiectasis. It's probably the first time she's ever heard that word in her life. She probably has a lot of questions about her disease. Someone who is born with a lung disease and has been in medical care for that disease since they were born, they typically speak the language. And so you want to respect the history and the knowledge that your patients have, really thinking of whether or not your patient is experiencing the education of their disease in an acute or in a chronic setting. So this would be a patient who fully understands what's going on, and you want to speak at the level of somebody who really understands their medical diagnosis. Looking at her skin is a really good clue to her hydration. Her skin is dry and she's pale in color. No neuromuscular deficits noted. She can do her own self-care. She's well coordinated with her movements. Upon inspection, you see severe clubbing of her fingers and toes. And when she coughs, you can see cyanosis of her fingertips, where she's not oxygenating well during that cough. Her posture is very reflexive it really demonstrates kind of the position that she's in. She's in a forward head, rounded shoulders, shortened pec muscles. She has overstretched posterior thoracic muscles and a kyphotic spinal posture. Now, the posture itself actually can give you a lot of information about the acute and chronic nature of a disease. If you walk in someone's room and they look like this, forward head, rounded shoulders, bent forward, struggling to breathe, if you ask them to sit up straight, and they can sit up and pull their shoulders back upon command, that is an acute posture in response to a difficulty breathing. She has maintained this posture for a long time. She has shortened pectoral muscles, overstretched posterior muscles, a kyphotic spine. This is all evidence of a chronic posture that she has assumed to help assist in her breathing. When you evaluate neck and chest, accessory muscles of ventilation were not marked at rest, but you do see them kick in when she goes to exercise. When you listen to her lungs, she has an expiratory wheeze, that'll be narrowing of the airways, which is consistent with all the mucus in her lungs. You hear crackles in both lung fields, and it's most pronounced in the right upper lobe. When you do a sputum assessment, you notice that she has increased production that streaks with blood. So she doesn't have frank hemoptysis. She's not coughing up blood, but there's some evidence of some leaky capillaries from the damage of the frequent coughing. So you do a 6-minute walk test. It's really important to assess a patient's aerobic capacity. Cystic fibrosis patients who are physically fit live longer. So this is a really important part of their treatment, is to keep them physically active. And aerobic capacity is a really good marker of disease severity. So a year ago, she did her 6-minute walk test, and these were her results here. So this is from 1 year ago. She was on 3 liters of oxygen. Her SATs ranged from 85 to 90%. Her heart rate was 150, her RPE was 14, and she was able to walk 1,400 feet. You fast forward to your 6-minute walk test of today. She's on a higher amount of oxygen. She has a higher heart rate response, a higher RPE, and she's going for a shorter distance. I think you guys get this in your Jerry class, but as a reminder, you can convert gait speed from a 6-minute walk test by taking the feet walk divided by 6 and then multiplying it by a conversion factor. So it can be kind of nice to do one test and get a 6-minute walk test and get a gait speed at the same time. You know, getting more bang for your buck, more data to collect to demonstrate progress and do goal writing. You can also predict their 6-minute walk test from the equation at the bottom of the screen here. I included in your note packet this chart of her actual 6-minute walk test results. So we can see the minutes here on the left. And we have her heart rate response, her O2 sats, and her dyspnea rating. It can be really helpful to talk to patients after their 6-minute walk test and show them how their subjective report of dyspnea correlated with their actual O2 saturation. Because patients who are out in the community are not monitoring their oxygen saturations, but these patients can get very good at recognizing their dyspnea. So you'll see that as her O2 sat goes down, her dyspnea rating goes up. When she gets into the lower 80s, this is when her dyspnea is 5, 8, and she actually needed to stop here and rest to allow that oxygen saturation, the dyspnea, to go back up. This can be so helpful for patients to recognize that their dyspnea is telling them about their saturation. They can use that as a trigger in the community to stop and take a rest, do some of their breathing techniques to get their oxygen saturation up. They can recognize dyspnea as a monitor that helps them know their oxygen saturation. So she was 2 out of 10 at rest, and it peaked at 8 out of 10 during the 6-minute walk test for her dyspnea. You do a strength assessment of her lower extremity, trunk flexion, bilateral upper extremities, and you see some deficits there. Her 5 time sit to stand is 12.2 seconds. So general goals for this patient would be to help enhance airway clearance, decrease energy expenditure, enhance physical tasks that help her return to community and work, improve functional capacity, promote independence with ADLs, reduce the risk of secondary impairment, and promote self-management of symptoms. So you'd want to use an aerobic intervention. The higher intensity, the greater the adaptation. You can use the heart rate range that you gathered from the 6-minute walk test to prescribe the intensity, so 70 to 85% of the heart rate range. Other measures that can be used, these are some of the quick and dirty clinical measures where you take resting heart rate plus 10 for low level exercise, or resting respiratory rate plus 4 to 10 depending on kind of where they are in the illness. Oftentimes these patients really benefit from interval training. So breaking up continuous exercise with the goal of getting strong enough that they can do continual exercise once they can get above 10 minutes in their interval training. 4 to 5 times a week. And they can do even more with interval training. You can see people tolerating 6 to 7 times per week. Flexibility exercises are really important because of the assumed postures that patients with a chronic respiratory condition get into. They get all this forward rounded posture that really works against them for getting nice big breaths. So doing a nice warm up to warm them up, and then picking 3 good exercises per session, spreading them out throughout the week. Cervical extension, bilateral shoulder flexion. These wall retractions are excellent because you pull the shoulders back. You have to keep the arms flat on the wall. The dowel rod stretch up the back, stretching the lower legs. Including these flexibility exercises can do a lot for their chest mobility and keep them moving. It's important when doing strength training that you include both upper extremity and lower extremity. Upper extremity strength really helps the muscles attached to the thoracic cage. These muscles all work together, and you can see carryover into quality of life and dyspnea ratings as their upper extremities get stronger. So you can do strength every other day, or you can rotate muscle groups and do strengthening every day. Sometimes it's a little easier for patients to do 1 or 2 strengthening exercises every single day rather than a big strength day like a healthy individual might be able to tolerate. Incorporate breathing exercises to decrease dyspnea during the exercises. Talking about paced breathing, kind of blow as you go during the work phase to allow that exhalation so they have control of their rate during the working part. Teaching patients about their entire soda can, about the role of the pelvic floor as well as their diaphragm and their abdominal wall in creating the stability necessary to do good strengthening exercises. Some patients may need to actively engage their pelvic floor to really get a good stable can. And then the last point in your notes I already mentioned, it's just how often you do the strength training will kind of depend on their personal preference. There's a lot of manual therapy that can help patients with chronic respiratory condition. Mobilization of the rib cage, thorax, pelvic, shoulder girdle can all help open up their chest, allow better movement of these integrated structures of their body. You can apply the principles of proprioceptive neuromuscular techniques to the chest wall. The picture of the gentleman on the slide is actually using a contract-relax technique on his pec muscles, and they showed increases in vital capacity with just a few sessions of pec stretching. So taking the time to address the muscular restrictions around their sick lungs can make a huge difference because they're not fighting the lung disease and a musculoskeletal problem. So when patients engage in improved ribcage and thorax mobility, we see decrease in rates in dyspnea, lower RPE during functional activity, lower complaints of shortness of breath, and improved quality of life. Massage can be great to help reduce the muscle tension of all of these actively engaged accessory muscles. It can really help reduce anxiety, which can sometimes be half the battle for a patient who is struggling to get their air to be successful in an exercise program. You can decrease work of breathing and enhance comfort. So you could use any number of your airway clearance techniques, whether it's breathing strategies, manual or mechanical techniques, or others. You find what works the best for that individual patient, what they're willing to do, what they're capable of doing, and then really make sure to teach it well so that it works for the patient and it gets them what they need. The last part of this lecture is a group of charts that I thought you might find helpful at this point, because sometimes it's hard to know, like, okay, I know that they have this disease. I know that it's impacting some degree of their function or causing some degree of disability, but when is it bad enough that it's the thing that I focus on? Like, when should I intervene? And that place where you draw the line that says, yes, I'm going to step in here, I'm going to make a PT goal, I'm going to make this a priority, is called a threshold behavior. So these are measurable behaviors at the pathology, impairment, functional disability, or quality of life level that triggers an intervention. So I have a number of these charts in your notes. You certainly don't need to memorize these. Some of them are really intuitive, but some of them less so. So I think it might be helpful to read through these, or if you're going on a clinical rotation where you're going to be treating patient with ventilation and respiratory issues, if their normal level is that they don't have any kind of increased work of breathing, and they present with an increased work of breathing at rest, this is a time to step in. This is an impairment that's going to impact their functional performance. So you have to address kind of why is their work of breathing gone up, and then work on techniques to either maximize ventilation, or maybe they need to just relax and get their anxiety under control, but that would be appropriate to intervene. If their baseline level of respiratory rate is 12 to 16 and it's increased at rest, why is it increased? This might be appropriate to do techniques kind of similar to the previous, or maybe the respiratory rate is related to an increased accumulation of fluid. If they have a temperature, they have a fever, this could be a sign of an infection. So they may need additional antibiotics or more aggressive clearance techniques. If they are accumulating CO2, they are not clearing that out effectively, they might need a more aggressive clearance techniques. If their FEV1 is not affected by bronchodilation, that's a sign of bronchoconstriction, they may benefit from a bronchodilator before they do their clearance techniques. As dyspnea goes up, you need to address what's causing the dyspnea elevation. If their fatigue is going up, what's causing the fatigue? You can do a similar thing with airway clearance, and I'll kind of let you read through these, but based on what you hear in the lungs, their PFTs, how much sputum is being produced, if they're coughing up blood, if their SATs are falling, if they're not doing what you prescribed, we're going to need to intervene. How much effort is required to get that done? If it is requiring excessive effort, maybe a clearance technique had worked for a while and it's not working anymore, it is time to come up with something new. I included in here the aerobic capacity and endurance threshold behaviors as well, although I think these should be familiar with you from physiology of activity. So this patient ended up receiving a lung transplant 4 months after this most recent episode. She had been compliant with her exercise program and doing her pre-transplant workup. The following assessments were made. So right before she got her lung, because she followed the plan put in place by her medical team at her last exacerbation, at that time she did her 6-minute walk test on 2 liters of oxygen. That's less oxygen than she had been. Like, she had gone from 3 to 4 liters previously. Now she's down to 2. Her SATs were able to hold at 90%, and her distance actually improved by 100 feet at a lower RPE. And on less oxygen. Let's not forget that too. Less oxygen, lower RPE, and she actually walked farther. She improved her aerobic capacity prior to her transplant. This is huge. The healthier her body is, the better that transplant is going to go. Her dyspnea ratings were the same at rest, but did reduce at the end of her 6-minute walk test. She saw increases in all of her strength, and her 5 times sit to stand time improved by 0.6 seconds. That's lower than the clinical detectable difference, but it's still progress that a patient made in a progressive lung disease leading into this major surgery. So that is our introduction to cystic fibrosis. Many of these patients, in order to make it into their later years, will require a lung transplant. So the best thing we can do is to help keep the rest of their bodies as healthy and as strong as possible, as much flexibility and mobility in their thoracic cage, that when they are living with this disease, they're the most comfortable they can be, they're the most functional they can be. And if they end up getting a lung transplant, their body is strong and able to survive that surgery and then live a full life with a new lung that doesn't have the same problems that they were born with. All right, thank you guys so much for your attention. I hope you're having a wonderful day.